Meeting is being recorded.
Good afternoon, everyone. Thank you for joining today's meeting. As you've just heard, this meeting is being recorded. Just want to make a quick note about your audio connection. All lines are muted upon entry. If you hover your mouse over the bottom menu bar, please click the button that looks like a speech bubble. This will allow you to send comments and questions via the chat box. To ensure that you are sending your questions to everyone in the group, in the to box, make sure it says all participants by using the drop-down menu next to it. We will begin in about 5 minutes or so. We want to give folks some additional time to join before we begin. Thanks so much.
Welcome, everyone. As Morgan mentioned, we have a large number of participants registered today, so we're going to give a few more moments to let folks log on and join us via this WebEx platform. We're going to start in 3 minutes. Welcome, everyone. This is Denise Solzbach. Thank you for joining for today's Managing Now for a Better Tomorrow conversation. I am the director of the National Center at the Institute for Innovation and Implementation at the University of Maryland, Baltimore School of Social Work, and the deputy director of the TA Network. We are going to be tweeting throughout this discussion. If you would like to join us, please use the hashtags Better Tomorrow and TA Network Talks, and tag us at Institute SSW. We want to open by, we recognize and hope that this conversation finds you safe and well today. This is a challenging time for all of us in children's services across the country, most especially for the families and youth we serve. We have created these conversations to give you peer-to-peer opportunities for you to be able to talk, oops, sorry about that. For you to be able to talk with one another and with the presenters. We encourage you to use the chat box to share your thoughts and resources, as well as questions for the presenters and panelists. When you use the chat box, please select all participants. This will allow everyone to see what you are sharing. In follow-up to today's discussion, we will send everybody who registered a link to today's recording, as well as resources and insights shared in the chat box. This is, as I mentioned, a series. We've had some very active chat box, and so we do rely upon you to help us share resources to benefit all. Because this is very much a conversation today. You're going to see our presenters and panelists joining us from their homes, as many of you are doing yourselves, and we will not be using a PowerPoint during the discussion. And this truly is a series about managing now for a better tomorrow. Together, we are stronger in creating forward-looking solutions to meet the challenges of today while building a brighter tomorrow. And we do value your participation in today's discussion. And we may especially need your partnership, as we all appear to have online connection issues at some point these days. Some of us had them while we were setting up the practice session. So if you lose us, please log back in. If we lose you, please stay with us. If you lose one of us, others will step in and cover. We have a troubleshooting team ready to assist, and we're getting pretty good at this. So this conversation series during COVID-19 is truly a series. We have recordings so far available for you on crisis communications. Those discussions were held on March 25th and 31st. We also had a discussion on in-home behavioral health, which was held on March 26th. In supporting families, we had overwhelming response. We reached our maximum capacity of 1,000 registrations for supporting families both on April 9th and April 13th. And you can have those recordings as well on our website, which we'll get to in a minute. We also had overwhelming response to our infant and early childhood mental health discussion that was held on last Friday, the 14th, and we're looking to schedule another one on that topic as well. Upcoming discussions include housing instability and homelessness. That will be held on April 24th at noon Eastern, as well as 2 discussions coming up on school mental health. They'll be held on April 22nd and April 30th. The one on April 22nd is going to focus on students and their families and caretakers, and the one on April 30th will focus on educators, teachers, and school administrators. We're also working on dates for you on supporting tribal communities, rural healthcare, and cultural and linguistic competency. To sign up for our conversation series, as well as to access other resources from our website, please go to the institute.umaryland.edu/COVID-19. You can also keep updated on our resources as well as upcoming discussions via the TA Telegram. That's our weekly e-blast newsletter of resources. And we can put, if you're not receiving the Telegram already, we'll make sure to put the how-to in the chat box. As you know, today's conversation is on mobile response and stabilization during COVID-19, and you're in for a treat with our presenters today. We're joined by Liz Manley. She's with us at the Institute for Innovation and Implementation. She's a clinical instructor. She is also with the TA Network, where she is not only the lead technical assistance support in many states across the United States, but she also leads our clinical workforce efforts as well. We're also joined by Dr. Christopher Balanci. Dr. Balanci is with the Judge Baker's Children's Center at Harvard Medical School, and Christopher serves as the medical director for the TA network. Also joining us is a panel that has been with us for several years now, working with us on our mobile response and stabilization academies and serving as faculty. We have Tim Marshall from the Office of Community Mental Health, the Department of Children and Families in Connecticut, Shamika Williams, the Children and Family Services in Oklahoma Department of Mental Health and Substance Use, and Ann Polakowski. She's with the Children's Services Department of Health and Human Services in Nevada. We also have panelists that'll be watching the chat box. We may be calling on them to respond to some of your questions as well. And our panelists include Bruce Cameron and Chris Morano, they both from Milwaukee, as well as Pat Hunt. And Pat is the executive director of FREDLA, which is the Family Run Executive Directors Leadership Association. So we welcome all of them here. We welcome you. And with that, I'm going to turn it over to Liz.
Okay, thank you for joining us today. I'm very excited about this particular conversation for a lot of reasons, but I wanted to make sure that folks understood what mobile response and stabilization is. We've been doing this work for a long time, and for those of you who are just joining us for the first time, I want to make sure that we're all on the same page. So as many of you are aware, mobile response and stabilization is an upstream intervention that is voluntary and initiated by parents, caregivers, and young adults themselves. The primary goal is to keep children, youth, and young adults out of higher intensity services such as emergency departments, inpatient units, residential interventions, and detention centers, and has great success in accomplishing all of them. Mobile response has had a significant impact on youth in child welfare, including foster care, and reducing the number of moves that a youth makes when in need of foster care. This work has never, ever been more important than it is today. And by that, I mean keeping children out of those emergency departments and inpatient units is of significant importance today. When a parent or caregiver calls for assistance, mobile teams go. They trust the assessment of the parent that there's a crisis that requires some intervention. And with that, we just go. With this in mind, what does mobile response and stabilization look like during COVID-19 is the question for today that I think we all need to think about. We know it's really important that we get this work done, and yet we need to think about how we're going to get it done safely. So today's conversation is not just about how states and communities continue to respond to families who are asking for assistance, but what does the future look like? What does life look like after this? And how do we get to that better tomorrow that we've been talking about? But before we even get there, I wanted to make sure that we talked about three really, I think, incredibly important topics. So I wanted to put them out there so that folks begin to think about it and maybe even share some thoughts and comments in the chat. So first, let's acknowledge that there's racial disparity in COVID-19. Black Americans are dying in greater numbers from COVID-19. We know that, we see that, and the evidence demonstrates that. So the question for us today is, what strategies do we need to have in place to address the disparity, and how do we meet the unique needs of children, youth, and young adults who have experienced the significant loss of family members, friends, and members of their community? And how do we address the economic challenges and food insecurities that come along with this? We also need to recognize that mandates that are happening right now in places like New Jersey, where I am, and in New York, require us to leave before we go into any restaurant for takeout or any food store. We have to have a face covering. This creates really important challenges for us and for our young folks as they are really trying to get the supplies and things that they need. And how do we keep them safe? I think the teams in mobile response are uniquely positioned to address some of these challenges because of the really special relationship with law enforcement and the ongoing work that happens on the ground in the communities. So I wanted to put that out there today so that we begin to think about that. We also need to acknowledge the challenges within the rural communities and frontier communities that may not have access to virtual technologies and are impacted by the lack of access to healthcare, reimbursement challenges, and may lack workforce. And so we need to think about those communities as well. And then, of course, the real big elephant in the room for a lot of folks is the trending downward of the calls that are coming in, both for child welfare and for the use of mobile response and stabilization. So we are hopeful today that we'll lead with ideas and resources and supports to address a lot of these challenges. But mostly, I hope today we have a conversation that allows us all to know that we're working together to try and solve some of these most challenging issues. Christopher, I'd like to turn over to you.
Thank you, Liz. I appreciate the framing comments. So I am the medical director. I'm a child and adolescent psychiatrist. And I guess the questions that come to my mind when we're thinking about how do you respond as a mobile response and stabilization service team, whether you're working on the team, administering the team, supporting the work of the team, given the challenges of this pandemic. And I think a number of obvious questions come to mind, so I'm just going to throw those out there and ask the participants to start responding to some of the questions in the chat box, as I'm sure some of our presenters will as well. The obvious one is, do you continue to send your workforce to do in-person mobile response assessments? If you do, how are you doing that and keeping the staff safe, as well as the people who you're responding to who are in crisis? What we know about the virus is that it can start spreading. We're not sure how long it can start spreading before you actually develop symptoms of illness, at least maybe 2 days, but it could be longer. And then we also know that some people are actually sick, but not significant enough to even be aware that they're sick. Their symptoms are so benign that they don't actually realize they're sick, but they're still spreading the virus. And so that invisible nature of this viral illness poses unique and significant challenges to the way we do our business. And so I'm curious whether or not jurisdictions are still sending out people to respond in person. If you are, do you have adequate personal protective equipment, PPEs, that we've all become part of our acronym, our language? Are you able to do that and provide your staff with the appropriate PPE? And if you're not doing in-person evaluations, how is that working in terms of your shift to some kind of a telehealth remote technology system? How do you ensure that the people calling for the crisis contact have the appropriate technology to be able to link with you? How do you ensure that your staff know how to use the technology appropriately? And how do you then figure out what the crisis response needs to be and what are your tools to be able to do that? So I think with all of these conversations, and we've had them now with parent-peer support workers, we've had them with in-home behavioral health workers, we've had them with residential treatment providers, we had them with infant and early childhood workforce, all of whom have some degree of direct personal contact. I mean, we are in the person-to-person kind of business, and it's very challenging for us to think about how do we provide the ultimate goal of our interventions without making either our staff sick or the patients or consumers that we're working with sick. And so I think this conversation is really about us thinking together about how to respond in this unprecedented time, given the unique challenges of the pandemic. So I'll stop there and come back in as needed.
Thank you, Christopher. Hey, Tim.
Hey, good afternoon, everybody. This is Tim Marshall from Connecticut. So just want to talk a little bit about Connecticut's experiences and where we're at right now. So we're in the really the fourth week of the week that most people started to head home to do virtual work as a whole. And our mobile crisis program, our mobile response system in Connecticut, about 4 weeks ago and 5 weeks ago, started to face some of the challenging questions that were just posed. Connecticut right this second is in one of the northeast sections of the hotspot. And it was last week and this week that it was predict that we would be in our peak exposure period. And so this week we're hoping that it's peaking and that we'll start to see some downside. But some of the lessons we learned first was early on, anxiety was incredibly high. So one of the things that we figured out in Connecticut very rapidly was to really touch base much more frequently with all of our mobile crisis providers, our mobile response system. We have 6 contracted providers, 14 sites, 150 staff. And so trying to just make sure we stay very positive. Also, one of the things we learned very quickly in the first few days, there was some tension around as contract managers holding the contractors accountable to maintaining that mobility. We were in Connecticut designated, all behavioral health folks were designated as essential staff. And so we wanted to keep our mobile clinicians mobile face-to-face for as long as possible. What we learned very quickly was giving them the opportunity to make the decisions and start to triage some of the calls to only go face-to-face on the most urgent situations. Once we gave that decision-making back to them, we found that both morale and anxiety went way down. They felt more control and then felt more comfortable making some of those decisions, whereas in the first few days, we kind of insisted as business as usual. We also just needed to acknowledge that and spend a lot of time reinforcing that our workforce in our mobile clinicians is rather young, often newly married or married for only a few years and with little kids. And so their anxiety about themselves and their children was obviously very high. So we really tried really hard to stay very upbeat and very positive. And I think there was very early on when we made that decision to defer the decision-making about the most urgent cases of calls and to families to continue to go face-to-face. We found that helped quite a bit. Before that moment, we started to hear worries from administrators because staff were calling out sick. Staff were saying they're just not showing up. And until we kind of communicated that their safety and our concern for them was number one, that was an important component. So we did that early on, and that started to help. The second thing we needed to do is to obviously change very rapidly kind of what the basic requirements for like paperwork and documentation. So we wanted them to be sure they're still having a tracking system and they're collecting appropriate data, but we did waive some of the more thorough assessments and things like that and given them more flexibility. We did move very rapidly to the majority of calls virtually. And so our provider network in Connecticut, we were just literally days away from promulgating Connecticut's Medicaid regs regarding telehealth. And so our Medicaid department released memos and bulletins that reflected the federal guidelines being reduced with some more flexibility. And so that really helped. So our provider network got up to speed very rapidly in terms of the very many virtual platforms. Early on, there were some struggles with HIPAA compliant platforms. And so there might have been some early usage of platforms that were not fully HIPAA compliant, but that converted in some situations within a matter of a day or two. So things moved very rapidly in terms of that. And then regarding families, there is a challenge, whether it's connectivity or whether it's hardware with a number of our families. And so we also approved just maintaining contact through telephone and telephonic response. So we had the range of telephonic treatment and intervention. We had the telemedicine that was fully HIPAA compliant. We had some in between there for some period of time. And then we still have, even active today, some face-to-face with all the appropriate safety precautions. Regarding the personal protective equipment, the PPE, we're starting to get those fuller protective gear out now. The medical stuff, there is just short supply everywhere, I think, in the country and certainly in Connecticut. So our behavioral health providers were not prioritized as the hospitals were. And as I think manufacturers got more on top of the production, we're seeing more distribution of those now. I should also say, those face-to-face assessments, both then and now early on, that was only if the 3 COVID CDC questions were answered negatively. If any of those were positive, then there would not be a face-to-face, and there would be kind of some holding some hands in terms of the best way to approach kids who are really in an urgent scenario of needing some kind of intervention. So in the worst case scenario, if it did need hospitalization, how was that handled so kids could avoid the ED as best as possible? What other things did we do? I think the other piece is, so overall, what we have found is that the mobile system has been down. At its peak, I think we were down about 80% of our call volume. I think we're hovering around 70 to 75% right now. So one of the things that we did that went live on Monday, it took us 2 weeks to stand up. We created a 1-800 parent caregiver support line, and just call in, and it was a different number, but we trained up the mobile clinicians to do a telephonic support and care, kind of compassionate presence, a non-clinical intervention, in hopes to reaching more of the general population, particularly families who are working from home and have kids trying to do virtual schooling from home, where tensions have been challenging and stressors have been high. So we have been in this soft launch since Monday, and we're getting small numbers of call. We have a hard launch going public tomorrow, with the governor making a full announcement and a full radio, TV campaign blitz to make that available. And we're hopeful that that will not only get to the general population more, but even those families that might have more historically utilized our mobile system, that they would feel the use of that support line and be able to outreach to that. So that's a handful of things that we've done. I think there are a bunch of lessons learned that I think for the better future. One is, again, I just want to reiterate, the other piece is managing the system. Is we went from normally what we do is monthly administrative management meetings with myself and our funding as the funder source. We've gone to weekly, and we do virtual face-to-face meetings to just check in. And we start every meeting and we ask every provider to share some really positive story that occurred. And it's just really incredible, the anecdotal stories, and they are contagious, and they really help drive and keep morale high and keep people very invested in the work. So we really encourage keeping morale high. And then some of the interesting things we're learning is there are actually some pieces of the virtual experience of the telemedicine that are actually we're going to probably try to hold on to after we get back to life to normal, because there's some really cool enhancements, in particular engaging younger kids and adolescents for a longer period of time on a virtual experience, and more engaged than might otherwise be in person. So we're really hopeful about starting to already talk about how to take the virtual experience and enhance it bit with the traditional experience of being face-to-face in all those situations. We did have one struggle with one team. One of their teams was members was exposed to a positive, did convert and exposed the entire team. So we had one part of our state that were did 0 face-to-face assessments for a couple of weeks. They actually went more than the 14 days. and are slowly getting back to being able to do some of that work. And of course, that sent that team and that organization's morale. It was a challenge for some bit. So you have to work harder at that, and then really work hard at keeping folks doing the work. It's just so important to keep the kids at this time who are really demonstrating high levels of clinical need and behavioral health need, just to try to keep them at home and in the community. So that's Connecticut's experience.
Thank you, Tim. That was very helpful. Before we go to our next presenter, I just wanted to bring a couple points forward so that folks have some chance to think about it. Number one, I did want to just make the point that to really highlight Tim's point that some of this technology that we're talking about now is incredibly helpful. So trying to keep track of the innovations and how the innovations are helping and what's working for children can be really powerful in this time frame. So we can figure out later, what do we need to continue and make sure that we're supporting through Medicaid systems and through other payment mechanisms. So I wanted to make that point. I also just wanted to highlight, there was a question in the box, or a comment in the box about families dropping out. And I wanted to see maybe if Tim had any of that experience before we go to our next.
Dropping out, we had a huge number of families that under normal circumstances would have definitely had a face-to-face assessment, and some who really probably needed a face-to-face but really wanted no one to come near them. So there was a protective factor that many families are going to themselves. And so it's really been some of those acute situations were and have been very worrisome, to the point where I think there's been I've heard of a handful of anecdotal situations where law enforcement might have been called or relied on. So it's a challenge for those. But yeah, we certainly saw a number of those situations.
So thank you, Tim. I'm wondering if Pat might be able to help us here in thinking about what is the best way to engage families in some of these conversations and what supports might be helpful for families.
I think we have to stop and think about, what works for them to have the conversation. Sometimes it's a simple conversation. I think families are feeling probably equally as overwhelmed as the rest of us at this moment, given they're doing all the things the rest of you are doing, like teaching their kids at home and trying to live up to all the other obligations, like doing groceries in a time when it's stressful to even do that. So I think meeting them where they are, offering them, if they can't think of solutions, offering them a variety of opportunities. And I think many people have been sharing in the chat box some examples of how they've been able to connect, how they've been able to get signatures, how they've been able to do this. And I think, a simple conversation, and it might not be so much about how you reach them as to when you can best reach them. And I know some agencies have talked about moving their hours to late afternoon and early evening, things like that, when parents may be able to focus a little better on their own needs and their own child's needs for services. So
thank you, Pat.
You're welcome.
I think that's very good strategies. So Shamika, would you like to share some of the innovations from Oklahoma?
Absolutely. Thank you, Liz. Again, a lot of our my conversation will be based around the rural nature of the state of Oklahoma. Oklahoma is rural in proximity, so we're very spread out in distance. Again, in Oklahoma, we did have a statewide mobile response and stabilization system in place. And with that system, we had activated a lot of telehealth, specifically due to the ruralness of our state. And so we were utilizing iPads and telehealth equipment in order to interface with families and parents in our local communities. The one thing that we also had that was really significant during these times was our partnerships with law enforcement and other healthcare professionals. And so as an example of those types of partnerships, in communities where we were providing telehealth services, oftentimes our police officers and our sheriff's departments are the front line. They get those emergency calls sometimes more often than we do. Although we have a statewide call center and a statewide system for those types of calls, our police officers and our sheriff's departments are often on the front line, and they actually sometimes get to those situations first. So that was very helpful from a state perspective. Very, very similar to Connecticut. Oklahoma, we kind of started around 4 weeks ago, really beginning to look at what shifts we were going to have to make in order to be prepared as possible for what was getting ready to happen. Of course, some of the federal requirements around utilization of phone and technology started coming down. And again, some of those things were already in place for us, so that really helped. At the state level, we started looking at everything from different resources that families could utilize for the purpose of assisting with them and their kids. As our schools were closing, kids are going to be home majority of the time. Working with our other partner agencies, such as Child Welfare and Juvenile Justice, on specific issues that may interact with their system for the population of kids that they work with. How do we make sure that our state mobile system is able to respond to kids of all sorts? And I think the number one thing that was really important for us, as we are a mobile response and stabilization system, and we look at that in a way of responding to crisis, but as well as responding to provide interventions for families to prevent them from moving full speed into a crisis episode. And so we began to look at our kids that were our high utilizers, our kids that had often utilized inpatient at a much higher level than the general population. And so we wanted to reach out to those families to put plans in place to how we were going to address the crisis if they should arise. And so that preventative work was very beneficial and effective for us. Our mobile providers, again, we quickly, for those that did not have for those that needed to extend the technology infrastructure, again, they began to order the iPads as well as order other technology apps and different things for the purpose of interfacing with families and for the purpose of getting those things out into the communities where families could interface with them. There was two things that they wanted to maintain in place. As an example, right now through our technology, we provide those assessments to make the determination if a kid needs to go into a higher level of care. And so we're able to interface with a licensed clinician to do those types of assessments. But one of the things that our providers also wanted to maintain in place is the ability for those kids to continue to get their medication needs met, as well as to continue, if in fact they could not stabilize the crisis through the technology, the ability for those families to come to the clinics and come to the centers to get their service needs met. What we found is that, again, very few of our families were more concerned about COVID and not wanting to make connections. So they were more willing to make adaptations and make adjustments in order to meet the needs of their kids. For those families that needed to maintain their medication, we looked for ways for them to do that, whether it was picking it up at the clinic, asking a set of questions, directing them a certain pathway so that they can do that. And then also providing crisis care through sometimes the two-way windows so that we can interact with those families in a way where it felt more like we were in an office type of setting. And again, like Connecticut, we wanted to know if you were symptomatic. We wanted to know, had you been in contact? We asked those questions before our families came. Very few of our families have access to that level of service, and we seem to be able to provide more stabilization pretty much in the community and in the home. Some of the things that we did notice fairly quickly was really not around the kids. It was primarily around the primary caregiver and the families. Families' anxiety levels were building. Again, a few of our families started losing jobs, and so they really wanted to more so for them, it was a crisis, and we know what those things can lead to. And so we wanted to make sure that we allow families to have those types of interaction and really begin to look at how we compare them with our peer supports so that they can continue to get their needs met when in fact they did not call their local provider in order to get their needs met. And so we quickly allowed the stabilization process to go longer What we know here from the state of Oklahoma is we have had several different crises, whether we're talking about tornadoes or the bombing, there's an after effect. And so as our crisis system felt a little stable because we were a little ahead of the curve with our technology infrastructure, we started looking at the long term. I think the great thing that we had that was of great value is, again, our partners here. I mean, as Tim and Liz, reaching out to other states that were in the depths of this pandemic, that were really in the situations that we were not in the state of Oklahoma, and learning from those other states around how are they addressing other issues? What do they see that's coming up that may not have come up for us at the time? And so I think that leaning on folks that your colleagues in areas where you may see, whether it's through the media or the news or just communication, that they are in the depth of this pandemic was extremely helpful. Some of the other things, again, as we talked with our other partner agencies, as we know some of our kids are in detention centers, and we know some of our kids are in group homes and different places like that, really strategizing around what that needs to look like, because those are community type settings, and really strategizing with areas. I mean, I got some of the greatest advice from Liz around, really those kids have to have an interaction. How do you create an opportunity where staff are able to, the same staff are interfacing with the same kids daily? And so if one kid is exposed or one staff member exposed, it doesn't expose the entire team. And so really thinking about that, I know some providers went to different shifts to the point where they were normally on 8-hour shifts, and instead of being on 8-hour, looking at 12-hour shifts in order to accommodate the ability for the same staff to interact with the same kids every day, more so than the overall team of staff that were interacting with those kids. I think that also some things that we're looking at now, as again, a lot of the things that Chris mentioned, just around, really relaxing again on standards and really looking at things that we can learn from this is very similar in our state. What we're looking at now and what are some of the things that we're predicting, again, if this happens, if again our state continues to grow in the numbers, what does that look like for us? But then also predicting once we get to the peak and we're on the downside, what happens? And as we all know that during those times, things begin to set in. The trauma from going through this COVID begins to set in, and how we will begin to address families, how will we begin to support the families. And so, again, strategizing around those efforts. One of the things that is really significant is the utilization of peer support. Our family support providers and their ability to connect with our families in ways, not just to talk about the children's behaviors, but allowing them to talk with families around areas such as, again, how do we begin looking at you returning to work, and what does that look like for you? How do we begin to talk to you about what food resources are in the community now that you're laid off? How do we begin to talk to you about how you're going to get your bills paid? Because those are the things that are on a lot of our parents and a lot of our families' mind. And so really, again, in the nature of a crisis, it may not look like a mental health crisis, but when families are in crisis, regardless if they can't get their basic needs met or when they can't get the physical health or the behavioral health needs of our kids, they're in crisis. And so we want to be able to respond to that. And so we've opened up a mental health line in our state to be able to support that. And again, we have consistent efforts to support our frontline staff, just like we support our families. And I think one of the things that we decided, and I think it was a good decision, we were in the mix of developing our Children's Behavioral Health Conference. We know that our Children's Behavioral Health Conference in the state of Oklahoma is a time for our staff to get renewed, re-energized. We bring families and youth to that conference. And we decided, we're going to bring it to them. We're going to go to a virtual platform because we want to continue to keep our families and our frontline staff uplifted. And so really recreating that platform, to not to say we're not going to do it, but how do we bring innovation where people are Zooming, where people are at home, where people are coming in from their phones, that even if you can't go on for a few minutes to an hour to a few days, And so I think really thinking about the future right now, what if this happened, then what, has been very significant, and then learning from other states that are going through this.
Thank you, Shamika. I have a couple quick questions that you might be able to help us with. One is, are there situations in which the local law enforcement won't respond because there is because of the whole COVID crisis? Has that been your experience?
That hasn't been our experience. Our state has really geared up around providing the protective equipment, and again, we did have a little shortage, but to our law enforcement, because we do, again, a crisis is an emergency, and it can be a safety issue, and so they have protective equipment, and we haven't had a situation where they would not assist us in a response.
Thank you. Another quick question. Is Oklahoma a state that uses peer support, correct?
Absolutely.
Can you
Peer
talk
support is
just for a second?
I think that, and it's interesting that you said that, because I think probably there's never been a greater time than now to have peer support as a part of your infrastructure, as a part of your frontline defense. There's nothing like another family member who is going through similar situations. I mean, our family members, our peers, some of our family support providers have 3 and 4 kids, and they're trying to figure out how to make it work at home, how to be the school teacher, how to be the mom, how to be the professional. And so I think that having that experience in a process of really stabilizing and working to stabilize families, having the ability to have that type of staff on the front line as a defense to intervene and help families who are really, again, their needs are at a different level based on the type of crisis we're in. So yes, we do have our family support providers are a part of our mobile teams across the state, and have been one of the most significant peer partners that's a part of those types of teams.
Thank you, Shamika. Hey, Pat, I was wondering if you could talk a little bit about the work of peer support during this time.
I will if I can get off mute. Thank you. We've heard over and over again how critical it's been to families who haven't been able to get even basic things like baby formula. They've had people who've been able to get it where they live and transport it, make a doorstep drop, things like that. I think peer support's been totally invaluable. People have been doing it for longer hours at a different time of day. Many family organizations actually start their work late in the day to be able to connect with families when they need it, or when they have the time and space to be honest about what's going on and share their concerns without, having their children hear all their concerns. And so I think they've been really on the front line of this with the families, and still being able to help direct them to the resources they need to provide support in a new way, to support the parent peer staff in new ways. Not always having an in-person staff meeting, but maybe a half-hour touch base in the morning, sending people pictures back and forth during the day, just like, here's my new flower blossoming and this is what stage it's in, or look how much my 4-year-old's grown this month, or, whatever, just to keep that human touch going with people so they don't feel isolated and they don't feel less part of a team. So it's been very crucial. I think they've been able to get information from families in a way that they need. And I know one of the big concerns is around abuse and neglect and domestic violence, and what's, could be going on in homes, that when people call, they need to be thinking of asking questions in a different way. And I think those parent peer support workers who already have established relationships with families kind of know how to ask the questions and to get folks connected where they need to be. So it's been powerful. It's been a lot of work, and boy, they're just keep it on out there. So we're proud of them.
Hey,
Hey, Liz.
thank you,
Hey,
Pat.
Liz, can I make a reference to something Pat said that just reminded me of something? One of the things that we had in our state that has been helpful, but it really changed a lot of things, is respite care. We had to make we became a little bit more flexible in respite care, because what happened is we encountered a parent who did not have the types of support that most of us had, and she was positive with COVID. But she had 3 kids in the home that were not positive. She was on a 14-day quarantine. And so things like respite care vouchers and the ability to provide that type of flexible funding during times like this was extremely helpful for her, because she did have a support system that was not a kinship support, but we were able to do the flexibility to offer those types of respite options so that, again, her kids wouldn't be caught in the same situation as her because they lived in the same home. And so things like that provides a little bit of flexibility to a mobile crisis system are extremely important.
Thank you, Shamika. So we have a question in the box that I think might be out to the full panel around the question around youth with autism spectrum disorder, and how can mobile response be helpful in engaging these youth, at least in the short term, given that schools are closed, and maybe coming up with a game plan for families. Any thoughts on that? Any experiences on that at this time?
I can speak from Connecticut. I haven't touched base with anybody specifically around since we've been in the COVID experience, but what we did do, and so I'm assuming it's being used today, each of our contracted agencies, we added a 0.5 FTE, so just part of a position that's really intended to be spread out through all the clinicians to have them be trained specifically on how to work with kids on the spectrum in an acute crisis, and concrete strategies that are used for that population. And in particular, with that, a direct linkage of those specialized clinicians to the agency that has full responsibility for kids with autism. And so there's a direct link for connectivity, so to speak, of those who have some responsibility to work with those families. So we kind of have a specialized, dedicated position to be able to spend more time directly working with that population.
Thanks, Tim. Anyone else want to weigh in on autism?
Well, I want to call out Cassandra in the chat, who had a great response. She and her team had 2 cases with a child having ASD, and they used a triage of a mobile crisis worker, wraparound, and positive behavior support, which was very successful. So I think thinking strategically about what the skills are that you would need to respond uniquely or differently. I also want to remind folks that, remind families that you can reach out to your local police department and embed into that an alert so that the police department knows that there's a child there with special needs, and you can even describe what the special needs are, what calming strategies might work more effectively. And I think that can also help to avert a crisis if the police department ends up being the first responder.
Thanks, Chris. This is Pat. Those were exactly my thoughts, to have families be a little bit proactive in reaching out and talking about peak areas of interest for that child, what kinds of things they focus on, what kinds of things have been successful in the past before there's a crisis, so that it's not as unnerving at the last minute. So.
Thank you, Pat. So I think that we have another question. Christopher, I was thinking we were going to ask the question around HIPAA. If you could address the questions around HIPAA real quick while I organize the next question around autism. Thank you.
Sure, and we happy to. And we did include some HIPAA compliant tool resources, the TA Network has a really nice resource on the website that I'm sure Michelle is typing in to the chat box as we speak. The rules around HIPAA have been relaxed somewhat. And so platforms that were not HIPAA compliant are being allowed for the period of the pandemic. I think if you're going to invest in a technology, it's still best to invest into a HIPAA compliant technology. I think there's been lots of social media reports about the limitations or concerns about privacy using the free Zoom platform. The Zoom Pro, which is the one you have to buy, is HIPAA compliant. People wrote in that they're using DoxyMe, which is another HIPAA compliant platform. You know, I think at this point, the most important issue is that you respond to the crisis. And if you're responding in as genuine and appropriate a way, given the limitations of the resources you have, at this point, I don't think people are going to fault you for that, particularly if you're doing it in the best interest of the family and your agency. That said, you know, do check out what the reports are, and I'll include again the information about the relaxation of the Office of Civil Rights around HIPAA compliancy.
Thank you, Christopher. So the question that I've been trying to get to is really this question about police engagement, and when you talk about children with autism, it gets really interesting around how police get engaged, in particular when there are flight risks. And so I think the question for the team is really around, and for the chat in terms of what folks have experienced is, are police responding to children who are demonstrating some behavioral health needs and some challenging behavior, or are they not? And if they're not, what strategies can we use? And I just want to preface this by saying it would be ultimately our goal not to have police respond in the first place, right? And to try and use the mobile teams as much as possible to keep law enforcement from even having to respond. And so I wonder if we have some real thoughts about how do we make sure families and children get what they need as much as possible to ensure that that doesn't happen. But I just want to make sure that this particular question gets answered. So if people have thoughts, both in the chat as well as from the panel, that'd be great.
I think within that, we have to remember that families have become conditioned to doing certain things when crisis occurs. And how do we support them to think about it differently and to sort of maximize their opportunities and to think about things differently. Now it's hard to, you know, we hear from families whose children are out of home or are in the hospital or are in congregate care. And it's kind of like they are terrified now about what's going on in those places. So we know that we all want to help families be able to keep their kids at home and still be able to deal with all the stress that's happening right now. So I just think when we think about what are they conditioned to doing, how do we offer new opportunities for them is key.
I think that's an excellent point. What are they conditioned to doing, and how do we offer new opportunities? And I think in the states and communities that have really invested in ensuring that there's access to mobile response and stabilization that really is seen as a helper and a deterrent, I think we need to make sure that we put the gas on and make sure that families really know that that exists. In the communities that are still struggling to bring mobile response and stabilization, I think we have to partner with law enforcement, and we have to let law enforcement know that we should take the lead. And I think we have to get to families where families are and let them know we're there to help in any means possible. So I feel like those are some of the strategies that would be really helpful for us to make sure that people are taken care of. Go ahead. Any other thoughts?
This is Tim in Connecticut. Again, this is prior to the COVID challenge, but one of the things that we did was to do the CIT training with law enforcement. We added the CIT-Y, the youth version. The youth version is an additional half day to another full day. And our mobile clinicians, our managers, co-trained that with law enforcement. And what we experienced was the secondary value of that co-training was way better than the primary purpose, because what happened was the managers developed very close working relationships with the law enforcement. And so it became really, really a great experience. And so, I just agree. I mean, we have too many experience again in Connecticut post Newtown when we increased our law enforcement presence in schools where that intervention backfired because law enforcement knows what law enforcement needs to do, and you end up having a negative impact on increasing school-based arrests for.
All right, so Tim has some technical challenges. I'm going to step in with a new question. Sorry, Tim, you froze there for a second.
Oh,
I'm going to
sorry.
with a new question that folks might have an answer to. I don't have an answer, but I would certainly love to hear what people are thinking about this. And that is anyone doing anything special in letting African-American families know how this virus is affecting them and what they need to be aware of? And do they need anything special? And I think that's a fabulous question that I think we need to really be thinking about. But I have a feeling some folks on this particular chat may have been already thinking about it. Anyone on the panel want to talk about that? Okay, so we're gonna keep working at that particular one, because I think we need, as a group of people who are working in the world of mobile response and mobile crisis work, that we really need to be thinking about how do we provide support and education to families around what is necessary in order for our families to take care of themselves. So I don't want to lose sight of that.
No, and I think we need to also consider while we're doing that, how do we respect what their cultural experience is? Because there could be very good reasons that that's happening, and how can we support them to stay connected in new ways if that's possible, and or desired even, you know.
Well, I agree. The cultural competence component is just really important, right?
Yeah.
And
Challenge.
right. I do think it's a complicated question, and with some work that we need to do in the future for sure. We did have an earlier question around whether or not folks are seeing any escalation in the number of youth who are hospitalized during this period of time. I was wondering if anyone had any experience around that, or whether you're seeing just a decline in phone calls.
I haven't seen any actual statistics or data. I do know that because there's a concern about having young people in any kind of congregate care setting, whether it's an inpatient unit, a residential treatment unit, for the same reason that we're concerned about nursing homes and the potential for contagion and spread, there's a active effort to try to avoid hospitalization. And similar to almost, what hospitals are doing in trying to clear out any non-essential patients there, to both make room for COVID-19 patients, but also to ensure that they're not going to catch any COVID-19 while they're there. I think there's people are bending over backwards to try to avert the need for hospitalization. And if it was my child, I would be doing the same. So my guess is that those inpatient units are down. Some, I think, out of an abundance of caution, have stopped taking new referrals. And I know that's true in the residential space as well, or trying to discharge anybody that doesn't have to absolutely be there, which is, of course, going to put a stress on the outpatient provider community, who have all largely gone to telehealth. So I think we'll need to see, as this goes longer, how sustainable that is and what the protocols will be to put in place. Minimally checking a temperature and assessing for whether or not the person meets the CDC criteria for correlation with COVID-19 symptoms is a minimal measure of protection, but it doesn't ensure that that young person doesn't have the disease, but isn't either showing the symptoms or is too early in the process to become ill.
Thank you, Christopher. Chris Morano, I was wondering if you could talk a little bit about some of the work that you've been doing and thinking about clinicians shifting their process around doing work virtually versus face-to-face.
Thanks, Liz. I've got some thoughts, and it's interesting because the American Psychological Association already in the earliest issue of the APA Monitor this year was highlighting how telehealth was going to be prominent this year before COVID. So a lot of the things that people have been talking about, good things, are just amplified now. So we've got, a country that is suffering. What we are underscoring and underlining here is that people have a profound sense of loss and a need for safety and predictability, and they're not getting it. So you pile on top of that the idea that people can't have physical contact with people. And what we know from trauma-informed care is that presence helps. Presence changes things, but we don't have that. So we're switching to virtual support, virtual telehealth, mental health. And what we still know, however, is that people respond automatically to, for example, changes in pupil size when they're in proximity to somebody. They respond automatically, they can't help it, unconsciously, to the tone of someone's voice, the facial expressions that they make. All of these things are a lot more challenging with telehealth, obviously. But what I want to suggest is, if this is going to remain, and I think it is, I think we're going to be doing, at least the same amount, if not more, of this in the future, is maybe we recalibrate our performance measures for our staff. And we think about how can we support staff in doing basic counseling skills, listening, not talking over the kid or the family, not asking too many questions in a row, not introducing our own experience too early in the therapeutic endeavor, because nothing happens without engagement or listening. And I think this helps us to really underline how important all of those basic counseling skills are, because all the other stuff is sort of fallen by the wayside. At the same time, a high challenge for us is, again, leaning on trauma-informed care. Interactive connection is so vital, so that, and we did a webinar on the strategies that the strategies that separate adult teams from child teams. And one of the things that we know is that kids are active. So one of the high challenges for MRSS teams is to try to develop strategies so that you can interact with the child, not just talk to the child, not just listen to the child and the parent as well. I like what Shamika said, we've got to really focus on parents and their needs. But if we're left to a flat screen, that really makes it complicated, complex to try to do therapeutic, interactive supports and strategies with kids and families. If I can just, Liz, if I can just add for a moment, there were the flurry of questions came in about texting, and that's, again, a really important area that has burgeoned in the last few years. Nancy Lublin has done great things with the crisis text line. Lots of states have MOUs about that. Lots of people are using it. People were musing about why are kids more likely to text. And of course, we know that kids are more likely to text than they are to pick up a phone. And some of the research done on this does indicate that if you're traumatized or if you've got sensitive personal information, sometimes literally hearing yourself say it is not desirable. Hearing your own voice deliver that information is really painful, so that texting becomes a much easier way to communicate that information. I just wanted to add that.
Thank you, Chris. I think Michelle Boardman wanted to step in just for a second, so.
Hi,
Hi, Liz. Thanks. I'm the director of marketing at the Institute, and I just wanted to jump in on the question that came up around how we're speaking to African American families around COVID-19. And I think it's important to stress two things. One is the physical aspect of this, that African Americans have a higher incidence of underlying health conditions. About 40% of the African American population in the United States are experiencing high blood pressure, and that it's those underlying health conditions which cause such a problem with COVID-19. And then the second issue is really around structural racism that impedes access to healthcare and also causes issues around access to food and the kinds of jobs and public transportation that people have access to that are likewise increasing both the disparity in healthcare, but also the risk factors for African Americans. So I thought that was just important to say. Both Chris and I shared a couple of resources in the chat, and we'll continue to look for more.
Yeah, and two more factors are playing into it. Living in close proximity to one another in urban density kinds of settings, and working in jobs where you don't have the option to work remotely. And that falls in a disparate way towards people at the lower socioeconomic level, which is often correlated with the structural racism that Michelle was just talking about, and poverty in general.
Thank you. Now we're going to hear from Ann Polakowski. Ann, you're up.
Hi, this is Ann in Nevada, and the benefit of going last is that all of my peers have done all the heavy lifting for me already and shared a lot of great innovations and interventions that they have implemented. I just want to share what happened in Nevada when this happened. Things moved very, very fast in Nevada, and the plan that I had on Friday, March 13th, when I left work, changed by Sunday night when I got the call that the governor had shut down all of the state services or all the state buildings except for essential staff, which mobile crisis was. When that hit, we were quite unprepared for telehealth to start. We had been talking about it for some time, but we did not have the infrastructure or the platforms, or frankly, any of the equipment that we needed to roll it out at that time. So we didn't have webcams or microphones and Wi-Fi in the building and any money for any platform. So that was the time when we needed to be very, very creative. And what I did have was very strong, dedicated, determined team who was set on keeping youth safe and keeping families supported and keeping our processes open and our lines open during this time. So I went to staff, I went to my community partners, we went to our rural partners who know nothing but telehealth and phone communications with our families, and we opened it up to everybody and said, talk to me, tell me what works, give me your ideas. We listened to the federal guidelines on the relaxations of HIPAA, which was really, really helpful for us for a lot of reasons, to include that we didn't have any money for a platform at that time, but also in opening up some things like Skype that was familiar to families. And so families said to us that they would rather do Skype over Doxy.me because it was familiar to them. It was something that they used. It was comfortable. I also utilized my 16 and 20-year-old kids at home and said, talk to me about these platforms. What are kids using? What works for them? And they gave me lots of feedback on what kids and teenagers were comfortable using. So we had to very quickly shift to telehealth, shift to getting verbal consents, which was new for us. We hadn't done that before. How do we get permission to be able to do these? How do we talk to families about if you choose Skype, it's not HIPAA compliant, and what does that risk look like? And my staff was just great. They were great at helping me figure this out, and they really did buy into the we're all in this together. And we listened to families, and what we found is that families didn't want us coming in their homes either. So staff who were having some fear and some anxiety about going out and exposure and all that unknown early on, families were having that same experience. And so when we offered things to them like phone consults and video consults, even though it wasn't familiar to them, that's what they wanted. That was their preference. And so that's where we shifted. And I think we've learned a lot, and we have a lot of room to grow as we move forward. But my message that I want to really share is you can do this without a budget, and you can do this without the technology to be able to do that. So that's where we're at in Nevada.
Thank you, Anne. I know that we're getting ready to, our time is getting ready to run out, but there's 2 questions that I know were in the chat that I just wanted to give folks an opportunity to talk about. And maybe Christopher could start with this. How do you know that a home visit might be necessary for folks versus a virtual visit? What would prompt a home visit?
Yeah, I was following the discussion in the chat around that, and it sounds like people have different kinds of screening protocols. So if there's a concern about imminent suicide risk, that seemed to be triggering perhaps more of an in-person response than a virtual, as well as whether or not there was any sense of imminent violence to self or others, which again is kind of in that same bucket. Somebody's typing in acute crisis. So, I think it depends on what your protocol is in the first place. So whether or not you have a coordinated response with the police or with an ambulance team, or whether or not you would normally handle those calls yourselves and then make a determination. Someone else is typing in psychosis. I think you want to balance what you know about what the imminent risk is to the individual or in the family with the potential risk of exposure either to your staff or to the family from your staff. And so it creates a different kind of a calculus. So however you were kind of managing these crisis calls in the past, I think we've got a different frame of reference now in the midst of a pandemic, a different equation. So I think it's really important to think that through, given whatever guidance you're getting from your governor, from your Department of Public Health around what is allowable in this kind of new order of concerns about how to minimize the spread.
Thank you, Christopher. We had 2 questions for Tim, or 1 comment for Tim and 1 question for Tim. So the question for you, Tim, is how do you get PPE? Who provides it for the teams?
Yeah, so in Connecticut, our department actually took a lead, and this is the first 2 weeks, it was very, very difficult. Everything was going to hospitals, but in the last 2 weeks, our fiscal department sent out a note to every provider and asked inventory about what programs are most in need. And then we actually placed the order for them, and the distribution really did loosen up, and I think they were moving those things very quickly. So we're still in a situation of helping to fill those orders, but we actually put ourselves in part of that role.
Thank you. And one of the comments was, would we be able to get more information and maybe as a follow-up on the training program that you've done? So maybe we can include some information in the follow-up to this group. Would that be okay?
Sure, the CIT youth component. There's yeah, sure, that'd be great.
Thank you, Tim.
Sorry, Liz, you were muted.
Yeah, I just noticed that. So I thought I hit the right button. What I was saying is, I'm wondering, as we're getting ready to wrap up, I'm wondering if any of the panelists had any comments that they'd like to share as we get ready to wrap up.
I do, Liz, and it's sort of like so evident that it almost doesn't bear saying, but I'm going to say it anyway. The impact on staff is enormous. Tim talked about it. It's been something I've been talking about for a while now. We've got to recognize the effect that this work has on staff, and to begin to make program adjustments, enhancements, whatever it takes to really become trauma informed and to allow staff recovery time, whatever it takes for them to reorganize themselves and to rebalance themselves in doing this work. And you know, it's really the foundation of what we do is helping the staff. And I think here in Vegas has had such a great response because she has a close-knit team, and team chemistry, team support is vital. If your idea of caring for others doesn't include self-care and team care, it's not enough.
Thank you, Chris. You're absolutely right. Spending time focusing on the workforce is really important during this time, with more communication than less, more engagement strategies, and when people need it, giving them the space and time that they need in order to recover and recoup, for sure. Let me just put a plug in for folks who don't know. The Mobile Response Affinity Group meets on a regular basis. It's an opportunity to share ideas. We do talk about workforce development and ideas during that time on how to take care of the workforce. We have an upcoming call scheduled at the end of April. The information is available in the TA Telegram. Okay, anyone else wanted to share any comments before we wrap?
Yeah, I just wanted to add to Christopher's comment around the acuity rate. What we found in Connecticut, we decided not to try to operationalize that. So most of the most acute situations that Christopher referred to are the ones that we are finding our folks are going out on. But it also connects back to Chris's comment, is we found the more control you give to each of the providers, the more comfortable they feel, the better decisions they're making. And we know that it also is not affecting the state geographically in the same way. So our southwest corner closest to New York City, which has the highest rates, that team is being a little bit more conservative. That was the team that was exposed. They were all into their own self-monitoring. And so we felt it was very necessary to let each of those teams operationalize exactly which ones were the most acute. But avoiding hospitalization, suicidality, psychosis, all those very high expression of behavioral health acting out, those were all the high ones. But outside of that, we really try to give them as much authority on that decision as possible.
Thank you, Tim. Okay, I'm going to just take this opportunity to thank everybody for joining us today. There are a couple of comments in the chat that we're going to follow up with. There is one from Veronica that I'm going to personally follow up with as I do work in Mississippi and have a lot of thoughts about how we can be helpful. I do want to thank everybody for their time today. I think it was really helpful for us. So there's a ton of resources that you shared, and I'm certainly very, very appreciative of all that we got to talk about today. Thank you very much.